Good afternoon. This is Malia Valentine from the Integrated Care Resource Center, or ICRC. Thank you all for joining us today for this ICRC webinar on state strategies for encouraging enrollment in integrated care programs. Next slide, please. Before we get started, I'd like to quickly go over a few logistics. For those of you joining by phone, you can view the slides by logging into Zoom. You can find the directions for doing that in the calendar appointment for today's webinar, which you should have received via email after registering. We will be recording this call, so you can revisit today's presentation or share the recording with colleagues who are unable to join. We will send you a link to that recording and the slide deck later this week. To eliminate background noise, all attendees' phone lines will be muted during today's presentation. We will have a Q&A segment at the end of today's webinar, but we will keep the phone lines muted. So we ask you to submit questions via Zoom using the Q&A icon at the bottom of your screen. You can submit questions during any point during the webinar. If you'd like to use the closed captioning feature, click on the More option in the Zoom toolbar at the bottom of the screen and select the Captions option. You are also able to edit the caption settings to adjust the text size by going to the Subtitles Settings option. As you leave the webinar, a short evaluation will pop up on your screen. We'd really appreciate if you would take just a minute to share your feedback. Next slide, please. This webinar is part of a series of 2023 ICRC webinars for states on steps they can take to promote integration of Medicare and Medicaid benefits for dually eligible individuals through integrated care programs, particularly programs that leverage Medicare Advantage dual eligible special needs plans, or DSNPs. Previous webinars in the series include selectively contracting with Medicare Advantage DSNPs to promote alignment with Medicaid managed care plans, leveraging the DSNP model of care to enhance enrollee care coordination, and using exclusively aligned enrollment to integrate Medicare and Medicaid benefits for dually eligible individuals. These webinars are available for your viewing on the ICRC website at integratedcareresourcecenter.com. Next slide, please. Our presenters today will provide a brief overview and benefits of integrated care programs, and then describe opportunities and methods for communicating the value of integrated care to dually eligible individuals, ways that states can collaborate with trusted partners to conduct outreach and education, state policy options to promote enrollment in integrated care programs, and additional factors affecting integrated care enrollment. We will save time at the end to answer audience questions. Next slide, please. We will hear from our ICRC subject matter experts today from Mathematica and the Center for Healthcare Strategies, or CHCS. Myself, Malia Valentine, Matthew Phan, Fariha Mujibudin, and Nita Joseph. With those brief introductions complete, I will kick off the presentation by providing an overview and benefits of integrated care programs. Next slide, please. We will begin today's webinar with background on integrated care programs and their value to dually eligible individuals and beneficiary choice of Medicare coverage before we discuss state strategies to encourage integrated care enrollment. Next slide, please. Today's webinar focuses on strategies to encourage enrollment into integrated care programs, but before we describe those strategies, we should first define what an integrated care program is. Integrated care programs seek to align the delivery, payment, and administration of Medicaid and Medicare services with the goals of improving access to and quality of care, eliminating incentives for cost shifting, and reducing spending that may arise from duplication of services or poor care coordination. We are going to focus on integrated care programs based on 3 different models. First, our programs developed with fully integrated dual eligible special needs plans, or FIDE-SNPs, and highly integrated dual eligible special needs plans, or HIDE-SNPs, which in some states qualify as applicable integrated plans, or AIPs. Second are the demonstration based on Medicare Medicaid plans, or MMPs. And finally, there is the Program of All-Inclusive Care for the Elderly, or PACE. The details of each of those models are written on the slide, and I won't read those out to you. Instead, I'll just say that these models are designed to provide comprehensive and coordinated coverage of both Medicare and Medicaid benefits and offer beneficiaries an opportunity to receive care in a coordinated and less fragmented way. The key feature of integrated care models is the potential for exclusively aligned enrollment. In D-SNP-based integration models, exclusively aligned enrollment occurs when the D-SNP only enrolls full benefit, dually eligible individuals who receive their Medicaid benefits from the D-SNP or from an affiliated Medicaid managed care plan offered by the same parent company as the D-SNP. States can require their D-SNPs, including FIDE and HIDE SNPs, to operate with exclusively aligned enrollment. The other types of integrated care models, the MMPs operating under demonstrations in their financial alignment initiative, and PACE organizations, have exclusively aligned enrollment as an integral part of their design. In integrated care models with exclusively aligned enrollment, a single entity has a financial stake in ensuring that enrollees receive high-quality, cost-effective care and avoid unnecessary hospitalization and institutionalization. On the next slide, we will discuss what individuals value about integrated care models. Next slide, please. We have strong evidence that dually eligible individuals find integrated care to be of value. On this slide, we will discuss some examples of integrated care's benefits to enrollees. However, we want to note that the benefits vary by program depending on a state's integration model and policy decisions. Dually eligible individuals value their care coordinators and the coordination of their services between physical and behavioral health care providers, long-term care providers, and social service providers. This ensures that all aspects of their care are well managed, reducing the risk of gaps or duplication of services. Furthermore, a single ID card instead of Medicare and Medicaid informational materials reduces beneficiary confusion. A single ID card means beneficiaries only need to present one card when receiving services. Additionally, a single ID card can ensure that providers and pharmacies are aware of a beneficiary's enrollment in an integrated plan for both Medicare and Medicaid benefits, which simplifies the coverage verification process and can prevent access to care issues. A single set of integrated materials can increase beneficiary comprehension, making it easier for beneficiaries to understand their coverage. Similarly, a single customer service line increases efficiency and reduces confusion for beneficiaries. For example, beneficiaries with inquiries spanning multiple areas or organizations can have their issues addressed seamlessly without having to navigate multiple lines of communication. Dually eligible individuals also find value in the simplified administrative processes related to appeals and grievances. The streamlined processes simplify the way consumers can raise concerns, seek resolutions, and communicate complaints regarding their healthcare services. Lastly, integrated care programs can provide an expanded array of benefits tailored to the needs of dually eligible individuals. Examples of expanded benefits include gym memberships, nutrition counseling, and debit cards for over-the-counter pharmacy purchases. If you would like to explore the studies from which these examples were drawn, we've included citations at the bottom of the slide. Next slide, please. Beneficiary choice in Medicare enrollment refers to the ability of individuals to select from various healthcare options available under the Medicare program. For example, beneficiaries may elect to receive original fee-for-service Medicare or enroll in a Medicare Advantage plan, including dual-eligible special needs plans, or D-SNPs. Medicare beneficiaries can select coverage based on the availability of preferred providers, pharmacy benefits, and supplemental benefits, as well as premium amounts and out-of-pocket costs. This approach empowers individuals to make informed decisions about their healthcare coverage, ensuring that they receive the services and benefits that best suit their unique circumstances. Although states cannot mandate enrollment in particular types of Medicare coverage arrangements, they do have opportunities to encourage beneficiary enrollment in integrated care programs through education and policy choices. We will discuss what those policy opportunities are, including mandatory Medicaid managed care enrollment, deeming, and default enrollment in later slides. Now, I will turn it over to my colleague Matthew to discuss opportunities states have to communicate the value of integrated care.
Thanks, Malia. And now we'll shift gears a bit and talk about some opportunities that states have to encourage enrollment in integrated care programs. And we'll go into some detail on some key considerations for beneficiary education throughout this process. Next slide, please. So one option for communicating the value of integrated care programs lies in broad public information campaigns. These campaigns are designed to reach large numbers of dually eligible individuals, as well as their families and/or caregivers, and can provide information about upcoming changes to programs or coverage options. States have a number of opportunities for conducting broad-based beneficiary outreach campaigns. These campaigns could be done to coincide with annual Medicare open enrollment periods, which occur from October 15th to December 7th each year, and annual Medicaid open enrollment periods, which occur from November 1st to January 15th for most states. Additionally, other opportunities exist when states award new Medicaid managed care contracts. Broad-based opportunities for communication also exist during the launch, expansion, or transition of integrated care programs. For example, the majority of states that launched the capitated model demonstrations under the Financial Alignment Initiative engaged in these kinds of broad-based campaigns to raise beneficiary understanding of upcoming changes. As such, broad-based public information campaigns can communicate the value of integrated care programs to a large population of dually eligible beneficiaries. Messaging, therefore, can tie back to the points that Malia made earlier about what beneficiaries find valuable about integrated care. Next slide, please. Another option for communicating the value of integrated care is through individual beneficiary outreach. While broad public information campaigns allow states to send out large-scale informational updates to their beneficiaries, individual beneficiary outreach can definitely also have value within this process. Individualized outreach is helpful when a beneficiary is experiencing a change to their eligibility or coverage options. Changes that might trigger outreach include when an individual becomes dually eligible, so either if they already have Medicare coverage and now become eligible for Medicaid, or vice versa. There are also opportunities to engage in individual outreach when a beneficiary experiences a change in residence or a change, could we go back one slide, please? Or when they experience a change in their Medicaid eligibility category, which will then make them either newly eligible for an integrated care program or can now make them eligible for other integrated care options. All right, now we can go to the next slide. So one great example of this individual beneficiary outreach strategy comes from Idaho. For its integrated care program, which is called the Medicare-Medicaid Coordinated Plan, the state sends out an auto-generated letter when one of its Medicaid beneficiaries becomes dually eligible by aging into Medicare or otherwise qualifying for Medicare. The letter that's sent out to beneficiaries notifies them of their coverage options. So one of these options is the previously mentioned Medicare-Medicaid Coordinated Plan, which is a voluntary program that integrates both Medicaid and Medicare coverage into a single plan. The other option for beneficiaries would be Idaho's Medicaid Plus program, which only covers Medicaid benefits and is not integrated. The letter emphasizes the benefits of receiving both Medicare and Medicaid benefits through a single integrated plan. And along with these letters, the state also distributes a program options worksheet that beneficiaries can use to help make informed decisions and learn more about their enrollment and program options. The worksheet promotes beneficiary choice and helps make beneficiaries more aware of the benefits they'd receive under Idaho's Medicare-Medicaid Coordinated Plan. States developing and implementing integrated care programs, therefore, could consider Idaho's example as a way to empower beneficiary choice during this process. Next slide, please. And finally, to conclude this section, I want to take some time to review 3 key takeaways. Firstly, beneficiaries have many options when deciding how to receive Medicare coverage. Secondly, integrated care programs bring value and benefits that beneficiaries would otherwise not receive from other coverage options. And lastly, states have opportunities to educate beneficiaries about integrated care programs through both broad and individual outreach efforts, and can time these outreach efforts to coincide with points where dually eligible individuals could benefit from having this information about integrated coverage options presented to them, such as during the annual Medicare open enrollment period, or when they personally experience a change in their eligibility or coverage options. And so to recap, we provided examples of when states have used both broad public information campaigns, such as with the model demonstrations under the Financial Alignment Initiative, and individual beneficiary outreach, such as with Idaho's Medicare-Medicaid Coordinated Plan within their integrated care enrollment processes. And with that information, I'll turn it off to Faria to discuss the methods of communication with you all.
Thanks, Matthew. Now that we've identified the opportunities states have to communicate the value of integrated care, we'll pivot to discussing the methods in which states can do so. Next slide, please. Prior to developing a communication plan, it's important for states to consider the beneficiary perspective and the questions they may have. Current and potential enrollees may have several questions around coverage options and how a coverage selection can impact how they receive care. The scope of these questions may depend on state-specific context and where your state is in its program evolution. For example, certain questions may come up for states transitioning from demonstrations under the Financial Alignment Initiative to new integrated D-SNP programs, or for states that implement default enrollment. While these questions will depend on where the state and the individual are in the process, they're important to consider in developing a communications plan and the key messages to be included. Next slide, please. States can use several different communication methods to support dually eligible individuals in understanding enrollment options and the value of integrated arrangements. While not an exhaustive list, examples of these methods include sending letters, conducting community outreach, and collaborating with trusted partners. We'll spend the next few minutes talking about each method. Next slide, please. The first method we will discuss is the use of letters. States may mail letters to those who become dually eligible and those who are already dually eligible to communicate changing coverage options and the value of integrated enrollment options. When developing letters and other supporting communication materials, states may wish to use plain language and a clear, accessible, reader-friendly layout. States can do this by avoiding unnecessary jargon and acronyms. For example, earlier this year, Mathematica conducted interviews with dually eligible individuals and found many of them did not know what D-SNPs were, despite the fact that their state has had integrated D-SNPs for several years. As a result, states may want to use state-specific program names rather than technical terms such as D-SNP and outreach materials related to their integrated care programs. In addition to using plain language, states should consider the needs of individuals with limited English proficiency, individuals with disabilities, and those with limited technological proficiency. To address language barriers, states can translate letters and communication materials into threshold languages for different geographic areas. If you'd like to learn more about communication accessibility requirements, we've included a link at the bottom of this slide to a resource page with helpful information on how to meet those requirements. Next slide, please. States can also tailor letters to align with specific beneficiary options, such as showing specific plans that are available by county. This will simplify the process for beneficiaries and allow them to know exactly what their options are when making an enrollment decision. States may also highlight key considerations from a beneficiary perspective, such as if the new enrollment option will change access to preferred providers and services. This may impact their decision to enroll in an integrated care plan, so it's important to include this information for their consideration. States can also incorporate clear and concrete examples of certain benefits that may come with integrated care plans. For example, rather than just saying plans will provide care coordination services, explaining that care coordinators can help you make appointments with doctors and specialists, set up transportation, and understand and access your plan benefits may be easier for beneficiaries to understand. With all of these considerations in mind, allowing for adequate time to test letter content and language with dually eligible individuals and obtain feedback from a beneficiary perspective will make materials more beneficiary friendly and can support enrollment. Next slide, please. This slide presents components that states may want to consider including as sections in their letters and corresponding resources, such as frequently asked questions documents. Starting at the top left, states can explicitly communicate the value of integration in letters and other materials. States may wish to also highlight how the integrated care program may look different from other coverage options, and states can lay out those coverage and plan options so that dually eligible individuals understand what their choices are. Beneficiaries may also need to know how these changes and options impact their care. Therefore, states may consider addressing what happens to the beneficiary's ability to see their preferred providers, as well as what may be included in their covered services. Letters and their supporting materials can then close out with information on next steps. Because recipients of these letters may be interested in understanding how to enroll or change plans, letters can provide dually eligible individuals with information on the steps they can take to enroll in an integrated care plan or other coverage options. These letters can inform dually eligible individuals of who to contact if they need help making an enrollment decision, and can refer them to enrollment counselors, such as the State Health Insurance Assistant Program, also known as SHIP, which we will talk about later. Finally, states can include where recipients of these letters can get more information. This can include pointing to additional resources online or in print, such as FAQ documents. It's important to note that the content of these letters will vary by circumstance and will depend on the state's landscape, such as if they're transitioning or implementing a new program. Next slide, please. California has recently transitioned from a demonstration under the Financial Alignment Initiative to an integrated DSNP program with exclusively aligned DSNPs. As part of this process, enrollees in demonstration MMPs, unaligned DSNPs, and DSNP lookalike plans in the 7 demonstration counties were transitioned to enrollment in exclusively aligned DSNPs. On this slide, we've included snippets of California's 90-day transition notice letter, which was mailed to enrollees in the demonstration, along with inserts addressing frequently asked questions and other integrated care options. This notice, which was tested on beneficiaries in the state, was sent by Medicare Medicaid plans to their enrollees to give advance notice of the upcoming transition. The phrases and components presented on this slide are intended to give some assurance to dually eligible individuals by addressing key concerns and questions from the beneficiary perspective, making them well-informed and more comfortable with the changes and choices around integrated care. California includes language that specifically indicates that the enrollee will keep all their Medicare and Medi-Cal benefits, and underscores that there would be no gap in coverage alongside this automatic transition, which can help prevent beneficiary concerns. The state's letters also give some flexibility for health plans to tailor the language to the specificities of the plan's coverage, such as including information about cost sharing and information related to whether or not the beneficiary's primary care physician is within network. When developing a communication plan, states can consider who the best messenger is for communicating the value of integrated care. A state can require DSNPs to notify enrollees through a state-developed letter about the options for integrated care. And in California's case, plans and advocates alike felt that this messaging should largely come from the plans. California tailored the DSNP notice letters to include specific information about how the transition would affect coverage and beneficiaries' access to providers. Next slide, please. As another example, in addition to some of the key components we discussed, Virginia developed a frequently asked questions resource in which they address why individuals should enroll in a DSNP in an effort to communicate the value of integrated care. The FAQ resource stresses that integrated coverage offers simplicity in navigating the healthcare system and care coordination to access needed services. Next slide, please. The state also includes the question of, should I align my DSNP enrollment with my Medicaid plan? Here, they list out what benefits aligned enrollment may offer the beneficiary. For example, this includes calling out that they will have one plan coordinating all care, integrated member materials, a comprehensive provider network, easier access to specialists that are contracted with both Medicare and Medicaid, and greater satisfaction in health outcomes. Dually eligible individuals are given a high-level list of the benefits of integrated care plans and steps to enroll. Next slide, please. While letters allow for states to directly communicate and inform dually eligible individuals, there are some limitations states may want to keep in mind when considering the use of formal notice letters. Oftentimes, mailed notices may not reach all dually eligible individuals due to issues such as incorrect addresses. Dually eligible individuals have also reported not fully understanding information or being overwhelmed by a high volume of mailed communications, which is why it's important to use plain language and pre-test the letter's content and language. Due to these limitations, states can also use creative strategies and collaborate with partners to communicate with dually eligible individuals, which we will talk about next. Next slide, please. Many states have engaged in a variety of community outreach activities to communicate the value and potential benefits of integrated care enrollment. Some states may choose to offer town hall forums in locations that are accessible to dually eligible individuals and at times that are convenient for them. States can support participation in these forums by offering options to participate by phone or video and providing interpreters or text telephone devices. States can also leverage websites, print materials, television, and radio advertising to raise awareness of integrated enrollment options and benefits. And lastly, community outreach can also be supported by using flyers, brochures, and other educational materials to share or post in community settings that are frequently visited by dually eligible individuals. Example settings may include congregate meal locations, senior centers, and food banks. Next slide, please. The last method in communicating the value of integrated care that we want to highlight is collaborating with trusted partners and organizations. States may find it beneficial to share information with state partners who can support messaging around integrated enrollment and educating dually eligible individuals. These trusted partners can be trained to explain the benefits of integrated care programs when Medicaid beneficiaries first become dually eligible or when asked about coverage options. Additionally, beneficiaries may be more likely to seek and follow counseling from entities that they believe are trusted resources. One example of such partners would be enrollment brokers. States may leverage working with enrollment brokers to align on state-specific messaging and campaigns through creating call scripts that address frequently asked questions and describe the value of integrated care plans. States can also partner with their state health insurance assistance programs, also known as SHIPs, to train and support SHIP counselors. States can conduct county-specific meetings with SHIP counselors to ensure they are equipped to educate dually eligible individuals and to get beneficiaries' feedback on experiences with integrated care programs and enrollment. Working with SHIPs can help states be proactive on eligibility issues or other problems that may arise. Organizations such as Aging and Disability Resource Centers, which work to address concerns faced by older adults and people with disabilities, can help share messaging around the value of integrated care to a wider range of dually eligible individuals. Next slide, please. Other groups that can help states share information and communicate with a wider range of dually eligible individuals include beneficiary advocacy groups and ombuds programs. These groups can help reach and communicate with beneficiaries and often have important roles in influencing opinions of dually eligible individuals and addressing concerns around managed care programs. States can also work with their senior Medicare patrols to detect egregious marketing practices that may add challenges to dually eligible individuals' ability to understand the value and choices around integrated care. Senior Medicare Patrol programs have experience assisting Medicare beneficiaries, their families, and caregivers to detect, prevent, and report Medicare fraud, waste, and abuse. Next slide, please. In collaborating with partners, states may need to think about how to frame the benefits of integration, not just for beneficiaries, but for providers as well. Providers may find that integrated care enrollment for their patients or clients can make for easier consolidating billing processes and enhance care coordination. Once providers understand the benefits of integrated enrollment, they can be key partners in communicating the benefits of integrated care and educating their patients and clients. Similarly, provider groups such as nursing facilities, assisted living providers, and home health agencies, as a few examples, can support these communications. Lastly, Other community-based organizations, such as area agencies on aging or faith-based groups, can help states reach diverse populations, support knowledge sharing, and build trust and integrated care within communities. Such organizations are often very familiar with the population and have established relationships as they directly work and interact with members of the community. In a study conducted for MACPAC, a Medicare-Medicaid plan and a demonstration under the Financial Alignment Initiative reported that working with community-based agencies like the Alzheimer's Association, the Primary Care Association, churches, and other community-based organizations who serve the same members encouraged enrollment. Another state worked with personal care attendants to help them understand the integrated care program, in this case, the state's demonstration, to engage with members more. The state noted seeing less attrition of their members due to this additional trust and engagement. Next slide, please. Now that we've covered information around considerations and methods to communicating the value of integrated care, we'll cover the steps that states can take to leverage these methods in the development of a communication plan. An important first steps for states is to define the target audience for communications. What you communicate will depend on if you're communicating the value to dually eligible individuals, providers, or organizations. The next step would be to identify the key messages you would like to communicate to your audience. Consider what the audience would find valuable about an integrated care program. Through these communications, states have the opportunity to shape the messaging that entities send out to potential enrollees. States can get state-specific information by collecting feedback from dually eligible individuals in integrated care plans and organizations such as SHIP counselors, enrollment assisters, and advocacy organizations. In some cases, a state and its contracted plans are involved in beneficiary education. In this case, the state can require its contracted plans to use certain language in their communications with dually eligible individuals to maintain consistent messaging and ensure accurate information. The third step in developing a communication plan is to establish timing. States can decide when it is an appropriate time for sharing information related to integrated care options to ensure that dually eligible individuals have sufficient time and information to make an informed decision. The final step is to consider what resources are needed to implement these communication strategies in order to effectively implement them. Next slide, please. This slide presents a state example of bringing together these various components for communication. Indiana is planning for the 2024 implementation of an integrated care program in which Medicaid managed long-term services and support plans will have exclusively aligned enrollment with DSNPs operated by the same legal entity. Indiana has developed go-live communication plans both for beneficiaries and providers. The state plans to employ various communication methods such as provider-facing and public-facing websites, beneficiary notices, and FAQs. It also plans to leverage new communication channels such as social media and interactive voice response messaging. Lastly, the state emphasizes developing unified messaging, engagement, and training through a communication guide that can be used by managed care entities and for providing training and engagement with other organizations. Next slide, please. Indiana's inclusion of the perspective of dually eligible individuals in its communication plan highlights a few helpful lessons. The first lesson is to identify and leverage key partners for messaging and strategy. The state acknowledged that its SHIP counselors had a more comprehensive understanding of beneficiary attitudes towards Medicare and Medicaid in the state and knew where individuals may be more difficult to reach. The state noted that early engagement with SHIP, holding regular meetings with SHIP leadership to build trust, and engaging with SHIP in communications such as letters gave the state invaluable perspective on beneficiary outreach and communications. Secondly, the state learned that it is important to simplify messaging as much as possible while still being effective and accurate. The language and methods used to talk about integration within the state Medicaid agency may not be the most relevant or effective when communicating these ideas with beneficiaries. For example, the state noted that beneficiaries often view their healthcare more simply, rather than identifying as dually eligible or distinguishing between their Medicare and Medicaid coverage. Next slide, please. Idaho is another state that leveraged different methods to communicate with dually eligible individuals when implementing its Medicare/Medicaid coordinated plan program. The state found that town hall meetings were most effective. In addition, Idaho encouraged engagement through postcard mailers for easier reach, including the department and state logo in its mailers, and hosting meetings in locations that are familiar to the public. The state held its town hall options in the afternoon or evening to meet the needs and availability of dually eligible individuals and their families. Next slide, please. To wrap up this section, I'll highlight some key takeaways when considering methods to communicate the value of integrated care programs. States can provide multiple opportunities for dually eligible individuals to learn about integrated care programs. States can achieve this by using a variety of methods to communicate with dually eligible individuals and ensure they are accessible to people with disabilities and those with limited English proficiency. States may also develop messages that highlight features of integrated care that are valuable for dually eligible individuals. For example, the ability to continue seeing preferred providers, benefits they cannot get through their current coverage, $0 cost sharing, and a single member ID card are considerations that may be influential in understanding and making decisions around integrated care. States can also partner with trusted sources of information. People may be more likely to enroll in an integrated care program if they believe the information they receive comes from someone who is knowledgeable about the subject, is trustworthy, and wants the best for them. I'll now pass it on to Nita to discuss policy options that promote enrollment in integrated care programs.
Thank you, Fariha. In this next section, we're going to go over a few policy options for states to consider to encourage enrollment in integrated care programs. Next slide, please. The first option we will discuss is around leveraging federal authorities to encourage enrollment into integrated plans. So states cannot mandate Medicare enrollment, as Medicare beneficiaries have a choice on how they receive their Medicare benefits. States do, however, have the ability to mandate enrollment in Medicaid managed care plans using federal authorities like the Section 1915B waiver and the Section 1115A demonstration. When states require dually eligible individuals to enroll in managed care plans for Medicaid benefits, they can promote enrollment in integrated D-SNPs and their affiliated Medicaid managed care plans by educating these individuals about the fact that they have two options for receiving their Medicaid benefits. The first option is to receive just their Medicaid benefits through a managed care plan, and then the other option is to receive all of their Medicare and Medicaid benefits through an integrated care plan. When these two options are presented side by side, many dually eligible individuals may find fully integrated option to be more enticing versus the Medicaid managed care plan alone with separate non-integrated Medicare coverage. The Idaho outreach letter that we described earlier in today's presentation is an example of how a state has approached this kind of education. For more information about the different types of federal Medicaid authorities that states can use when developing and implementing integrated care programs, please check out the ICRC tip sheet that we have referenced on the bottom of this slide. Next slide, please. Next, we'll talk about how implementing deeming periods can encourage enrollment in integrated care programs. States have the ability to require D-SNPs to offer enrollees an eligibility deeming period, which is a limited period of continued enrollment in the D-SNP if an individual loses their Medicaid eligibility. Deeming periods are only applicable for individuals who are expected to regain Medicaid coverage within 6 months. And according to CMS guidance, deeming periods can be between 30 to 180 days in 30-day increments. All D-SNPs can elect to offer a deeming period, but states can require a minimum deeming period in their state Medicaid agency contracts with their D-SNPs. So for example, some states have chosen to require D-SNPs to implement a 90-day deeming period to align with the state's reinstatement and/or automatic re-enrollment periods for Medicaid. This can also help to prevent unnecessary disruptions in care during short-term period of eligibility loss. During deeming periods, D-SNP enrollees who have lost Medicaid eligibility can remain enrolled in the D-SNP until the deeming period ends. This gives them time to reestablish Medicaid eligibility And the DSNP can also reach out to their enrollees to help with regaining Medicaid eligibility. One complications for enrollees during the DSNP deeming period is the fact that enrollees will have lost their Medicaid benefit, which means that they may also owe cost sharing for services that they received during that time, since Medicaid doesn't cover cost sharing during periods of lost eligibility. But DSNPs and their affiliated Medicaid plans, when applicable, can choose to cover cost sharing and or Medicaid covered services during deeming periods at their own discretion, and cost sharing as long as those services would normally be covered by the DSNP or its affiliated Medicaid managed care plan in the plan's capacity as a state contracted Medicaid managed care plan. One benefit to implementing deeming periods is that it can help preserve aligned enrollment by preventing someone who temporarily loses Medicaid eligibility from being automatically disenrolled from the DSNP and then left without the plan's care coordination services as that loss of eligibility takes place. And another benefit is that enrollees can keep seeing their providers that are part of the DSNP's network, and they can continue to receive the DSNP's care management services as well. Next slide, please. The next policy option we'll cover is default enrollment into a DSNP. With this option, if an individual is already enrolled in an affiliated Medicaid managed care plan, default enrollment allows for that person to then be enrolled into its DSNP once they become eligible for Medicare. If the individual does not want to be enrolled in the DSNP, then they can opt out of the DSNP default enrollment and instead receive Medicare benefits through either fee-for-service Medicare, a different DSNP, or another Medicare Advantage plan. This policy option also encourages exclusively aligned enrollment because it's only allowed in cases where the person would continue to receive Medicaid benefits through the same parent organization before and after default enrollment. Anyone who accepts default enrollment into a DSNP will get their Medicaid benefits through the DSNP or a Medicaid managed care plan that is affiliated with the DSNP. It's important to note that to implement default enrollment, the DSNP has to first receive approval from both CMS and the state. In their SMACs, states can allow or require DSNPs to obtain approval from CMS to conduct default enrollment if a DSNP shares the same service area as its corresponding Medicaid managed care plan, and of course meets other requirements. One of the challenges with default enrollment is the potential to not clearly communicate the change and how it will be valuable for enrollees to remain in the DSNP. To avoid disenrollment, in addition to the plan communication letters, states can consider having the DSNPs make welcome calls to new enrollees to explain their benefits within the first few days of their new DSNP enrollment. Some states and DSNPs have found that this helps to retain enrollees because they quickly become acquainted with the plan, the benefits it offers, and how to access those benefits. It's also important to note that states play a key role in default enrollment as well. States have to they have to work with DSNPs to identify people who are enrolled in Medicaid managed care plans who are becoming eligible for Medicare in order to help the DSNP identify individuals who are eligible for default enrollment. You can check out ICRC's default enrollment tip sheet that's linked on this slide for more information about this. Next slide, please. In this slide, we wanted to provide an example of what communicating with beneficiaries about default enrollment would look like in a state. Virginia is one of the states that implements default enrollment into their DSNPs, and they work with their DSNPs to provide notifications to those who are eligible. In addition to the notices that its DSNP sends to beneficiaries about their eligibility for default enrollment, Virginia also sends a notice from the state as well. The state's notice is mailed before the DSNP's notice, and it alerts beneficiaries to the fact that they will also be receiving a letter from the DSNP soon and about the default enrollment process. That way, the beneficiary can watch out for the letter and then pay attention to the instructions and information that's found in the letter. The state's notice also explains the benefits of aligned enrollment in a DSNP and an affiliated Medicaid managed care plan for both Medicare and Medicaid benefits. It also shares how the beneficiary can learn more about the benefits that are offered by the DSNPs and it provides contact information for 1-800-MEDICARE and the state's SHIP program to get help with understanding and navigating Medicare coverage options. Sending an additional letter on a state letterhead like this can help to ensure that the duly eligible individuals who are eligible for default enrollment actually open and pay attention to the notices that they receive from the DSNPs regarding default enrollment. State notices can also lend objectivity and legitimacy to the process as a whole as well. Next slide, please. Before we move on to the next section, I wanted to leave you with a few key takeaways on state policy opportunities to encourage integrated care enrollment. States can mandate enrollment of duly eligible individuals in Medicaid managed care plans, which can help to facilitate aligned enrollment in DSNPs and their affiliated Medicaid plans if states educate duly eligible individuals about their option to enroll in Medicaid-only managed care versus integrated care plans. Deeming can prevent an individual from being disenrolled from a DSNP following the temporary loss of Medicaid eligibility, and then provide the individual time to regain it. And lastly, default enrollment allows a DSNP to enroll an individual who is already enrolled in the DSNP's affiliated Medicaid managed care plan when the individual becomes eligible for Medicare. Next slide, please. Okay, in this final section, we're going to cover some additional factors that might affect integrated care enrollment. Next slide, please. States that are building integrated care programs should be aware of factors that may create challenges as the states aim to promote enrollment of dually eligible individuals into integrated care plans. One example of such a factor is market competition in states with a high number of competing Medicare Advantage plans. Dually eligible individuals can change plans more often than people who are only eligible for Medicare. So Medicare Advantage plans tend to market specifically to dually eligible individuals throughout the year. This kind of targeted and frequent marketing by competitors and independent agent and brokers can make it difficult for DSNPs to retain member enrollment in markets with lots of competition. States may also want to pay attention to marketing activities by Medicare Advantage plans that enroll large populations of dually eligible individuals referred to as DSNP lookalike plans. These plans have become more popular in recent years, but they are not held to the same requirements as DSNPs or offer all the same benefits for dually eligible individuals as DSNPs. A recent study that we cited at the bottom of this slide found that nearly 1/3 of dually eligible individuals who enrolled in DSNP lookalikes between 2013 and 2020 were previously enrolled in integrated care programs. Next slide, please. If a state has reason to believe that a Medicare Advantage plan is engaging in inappropriate marketing practices, one option is for the state to partner with the state's Senior Medicare Patrol Program to help understand, identify, and report these kinds of issues. Also, the Medicare Advantage marketing rules are explained in the Medicare Communications and Marketing Guidelines, and we've included a link to those guidelines here for anyone who might be interested in learning about the rules that CMS puts forth for these plans. Next slide, please. It's also important for states to consider some of the common reasons why dually eligible individuals choose to disenroll from integrated care plans in order to be prepared with solutions to prevent and address unnecessary disenrollment. Provider networks are an important consideration for dually eligible individuals joining and remaining enrolled in integrated care plans. Dually eligible individuals may disenroll from integrated care plans due to changes in provider networks or due to a network that's not broad enough to cover all the providers that they want to see. Many dually eligible individuals have built relationships and trust with their current providers and will choose or change plans based on whether they can still see those providers. This means that providers' willingness to join a plan's network and providers' ability to see the value of integrated care often is just as important as the beneficiary's ability to see it themselves. Providers have an influence on dually eligible individuals' enrollment and disenrollment choices, and a provider who sees the value of integrated care plans may be more inclined to promote integration with their patients or clients. States can add requirements to their state Medicaid agency contracts around provider network adequacy that require DSNPs to contract with specific providers within the state, such as HCBS providers or FQHCs, or providers that meet the cultural and linguistic preferences of dually eligible individuals. States can also require DSNPs to offer providers single case agreements when it is not possible for the provider to join the network. For the DSNP, this will help to ensure that the enrollees can access the providers that they would prefer. And as I noted previously, loss of Medicaid eligibility also has the potential to result in DSNP disenrollment. Because significant proportions of dually eligible individuals will lose eligibility at some point, often on a temporary basis, the eligibility deeming period that I discussed in the previous section are a useful tool in helping maintain enrollment in integrated care plans. States may also require DSNPs to work with beneficiaries to help them with eligibility redetermination paperwork or assist them with regaining Medicaid eligibility during the deeming period. And finally, if a Medicaid managed care plan that has exclusively aligned enrollment with the DSNP loses a contract in the state Medicaid reprocurement, enrollees in that plan may become unaligned. In this scenario, states may be able to work with CMS to enroll those individuals into another exclusively aligned DSNP through the passive enrollment authority that CMS has established in federal regulations. Next slide, please. Okay, so to wrap up this section, I wanted to leave you all with a few key takeaways. So first, it's important for states to report suspected marketing violations by Medicare Advantage plans to CMS for potential investigation, because this can affect, or it may affect, enrollment into integrated care programs. Also, states can monitor enrollment trends and identify causes of planned disenrollment to proactively work against it. And then finally, to promote enrollment in integrated care plans, states can use their contracts with DSNPs to promote robust provider networks and to require DSNPs to provide a deeming period. Okay, that's all I have for now. I'm going to pass it over to Lita to lead us in the question and answer portion of this call.
Thanks so much, Nita. So now I would like to take a moment to invite questions for our presenters. As a reminder, please feel free to share your questions through the Zoom Q&A feature by clicking on the Q&A icon at the bottom of your screen. And so we do actually have a couple of questions here that we can start with. And I have a question that Friha, this is a question for you. So the question we have here is, we understand from firsthand experience how providers can steer beneficiaries on enrollment decisions. You talked about how states can work with providers and provider associations to help them see the value of integrated care. Can you talk about what providers may find valuable and how we might partner with them?
Yeah, thanks, Lita. As we mentioned, many dually eligible individuals have built relationships and trust with their current providers and may choose plans based on whether or not they can still see their providers. Providers may not necessarily encourage patients or clients to enroll in an integrated care plan if the provider is not within the plan's network. This can be due to not understanding the value of integrated care for the patient or client and directly for the provider themselves. Also, depending on the provider and the state's integration landscape, what they may find valuable can vary. Besides the benefits to the patients and clients that we mentioned at the beginning of the webinar, providers can also find it potentially valuable to have a consolidated billing process so that providers don't use separate billing processes for both Medicare and Medicaid, integrated benefit determinations, and a unified plan level appeals and grievances process, as well as enhanced care coordination that can improve collaboration, care plan development, and beneficiary health outcomes. We would also encourage engaging with providers and asking them to find out more about what providers would want in your state. Several states that have implemented successful integrated care programs have used work plans, work groups, town hall meetings, and other techniques to successfully engage the providers and also solicit their feedback about priorities and concerns.
Thanks so much, Priya. So just again, another reminder, if you have any questions, feel free to use that Q&A feature. And we would be happy to answer them. So we do have another question here, and I think this one is for you, Matthew. So earlier you mentioned that states can educate duly eligible individuals about integrated care programs when a new Medicaid managed care contract or D-SNP contract is awarded. What do you mean by that?
Yeah, that's a really good question. So when a state reprocures its Medicaid managed care contracts, it could end up adding or removing plans in certain service areas. That means that states could use these broad-based campaigns to alert their duly eligible individuals to these changes in the plan options. And then additionally, in some cases, even if the plan changes made in the reprocurement don't directly affect the integrated plan options available, the state may wish to leverage these notices to particular Medicaid managed care enrollees to help them educate themselves on integrated care options. So for example, if a state is notifying a duly eligible individual that their current Medicaid managed care plan may, let's say for example, may no longer be contracting with the state, and that person then needs to choose a new Medicaid managed care plan, that'd be a great opportunity for states to also include a note or two about the integrated plan options that are available, or the benefits of enrolling in an integrated care plan and how the individual can best find out more about that. And so if that person was not in an integrated plan previously, seeing that information within the notice about their Medicaid managed care options might actually help them to become more aware of the integrated care program and may ultimately prompt them to enroll in an integrated plan. So that's definitely a great opportunity for communications in that regard.
Thanks, Matthew. And I'm just going to give folks just some time to drop in any questions that they have. Oh, okay, so we have another question here. This one, I think it's from Malia. So it says here, you discuss the different integrated care programs that exist and the benefits duly eligible individuals may find valuable. Are the benefits you shared offered by all integrated care programs?
Thanks, Lita. That's a great question. Each program offers different value to dually eligible individuals, and each program's benefits may vary by state depending on their integration landscape. For example, states that have exclusively aligned D-SNPs can require D-SNPs to use integrated communications and marketing materials that describe Medicare and Medicaid benefit and coverage information in a single set of materials. Exclusively aligned D-SNPs can also use simplified administrative processes that can be easier for enrollees to navigate, such as integrated benefit determinations and unified plan-level appeal and grievances processes. States' policy and program decisions can cause variation in what benefits are offered to dually eligible individuals in a particular state's integrated care program. As a result, it is important for state Medicaid agencies to seek feedback from dually eligible individuals in your respective states to identify what those individuals find valuable about the integrated care programs in the respective states, or what they would like to see in an integrated care program if you were thinking about designing one.
Thanks, Malia. Okay, and we have one more question here, and this is for Priya. You talked about beneficiaries not knowing what D-SNP or care coordinator mean. Most of our beneficiary resources and letters refer to these terms. How can we change how we describe these terms to be more reader-friendly?
Yeah, thanks, Lita. So trying to explain the benefits and elements of these terms in integrated care programs in simpler or more concrete language can be helpful. And typically the best way to consider the perspective of duly eligible individuals when developing these materials is by testing the language for those materials with duly eligible individuals in advance. States can also obtain feedback from community-based organizations, advocates, enrollment assisters such as SHIP counselors, who work closely with dually eligible individuals on a day-to-day basis and may have a more detailed understanding of the information and descriptions that would resonate with the people that they work with. In addition to kind of using simple language and avoiding jargon and complex terminology, it's also important to remember to offer materials in a variety of languages and accessible formats to help dually eligible populations generally understand that the information being shared. And when translating materials into non-English languages, leveraging local organizations or entities that are familiar with the dually eligible audience can help achieve more culturally appropriate messaging as well, rather than literal word-to-word translation, in which some of the benefits and nuanced messages such as care coordination can often get lost.
Great, thanks so much, Bria. And we do have another question here. When was the last time the marketing guidelines were updated? So the Medicare Communications and Marketing guidelines were updated in March of 2022. That is the latest version of the requirements. Great question. Okay, and we have one other question here too. So this is for Nita. We are interested in implementing default enrollment. How does a DSNP get approved to use default enrollment?
Thanks, that's a good question. So DSNPs have to get approval from CMS for default enrollment, and CMS will only grant that approval if the DSNP meets some specific requirements, like having approval from the state. In the state's DSNP contract, a state can allow or require DSNPs to request CMS approval for default enrollment. In other words, while the ultimate approval is granted by CMS, the state also has to figure out, or if it would allow the DSNP to use default enrollment. After getting state approval, the DSNPs have to submit a proposal to CMS, and then they also have to have a minimum overall quality rating of at least 3 stars and not have any restrictions on new enrollment imposed by CMS. The DSNP also should be able to show CMS that it has a system in place in partnership with the state to be able to identify who would be eligible for default enrollment and issue notices of at least 60 days in advance of the default enrollment effective date. Those notices must also meet CMS's requirements. We do have more information about default enrollment in that tip sheet that I mentioned during the webinar, and we provided a link to that tip sheet in the slides that we will send out after the webinar. ICRC and MMCO can also provide direct TA to states on this topic. So if you would like some one-on-one assistance with this, please feel free to reach out to us.
Great, thanks so much, Nita. And we do have a question, another question here. So this may be a question that we could have MMCO join us in answering. What new changes to the integrated landscape are being planned at the federal level?
Lita, this is Erin from ICRC. I'll just I'll mention a couple of things that are already happening, and we can see if any of the MMCO folks are able to jump in and fill anything that I missed here. You know, I doubt that anyone at CMS can speak to anything that might be being considered that isn't publicly released, certainly, but in terms of things that are public, there is a new opportunity for states now to partner with CMS in monitoring and oversight of DSNPs when states have some of these DSNPs that operate with exclusively aligned enrollments. Malia mentioned early in the presentation today that having exclusively aligned enrollment where someone who enrolls in a DSNP is also going to get their Medicaid benefits from that DSNP or from a Medicaid plan that is affiliated with the DSNP it's sort of the most integrated level that you can have in DSNP enrollment. And when states have DSNPs that are operating in that way, states can now require those DSNPs to operate within what are called DSNP only contracts. And that creates some new opportunities for the state in terms of being able to monitor the performance of those plans, being able to see quality measures that are always done at the contract level in a way that will show performance only for those DSNPs now, instead of showing performance for a variety of other types of Medicare Advantage plans that might be in that contract, for example. So that's one example of something that is new in the integrated care landscape and that states are able to leverage. There are states that are leveraging it for 2024 and some that just notified CMS. You had to notify CMS in August if you wanted to, in August of this year, if you wanted to use it for 2025. And some states will be planning to use it for 2026. So that's a great new authority that states can use. There are also some new rules on the horizon for 2025 for those fully and highly integrated DSNPs. And we do have a tip sheet on the ICRC website, and we referenced it earlier in the presentation, the slide where Malia mentioned the different types of integrated care, and we explained the FIDE SNPs and the HIDE SNPs. There is a link on that slide to our tip sheet that gives the definitions of those different kinds of DSNPs. And we have lots of details in that tip sheet about what those new rules for 2025 look like in terms of what FIDE SNPs and HIDE SNPs will have to do in 2025 that looks a little bit different than the rules that exist today. So those are a couple of things that are going on that are helping states and CMS continue to work with these kinds of integrated plans to progress toward further integration of Medicare and Medicaid benefits for dually eligible individuals. Certainly want to welcome if there is anybody at MMCO who wants to jump in and add anything to what I just said there. Please do feel free to share.
Thanks so much, Erin. Okay, we'll see if there are any other questions that folks would like to drop in the Q&A. Okay, well, seeing no other questions, if we could please go to the next slide. Okay, so thank you again to all our presenters. If you would like to revisit today's conversation and the slides, a recording of the call and the presentation will be uploaded to the ICRC website and shared with all call registrants via email. I urge you all to visit the website where you can find links to past ICRC webinars, as well as a variety of written tools, and states can also submit requests for technical assistance. We hope this webinar has been valuable to you all today. If you are logged in to Zoom, please complete the survey that will appear at the end of the webinar. We're looking forward to reviewing your feedback and making changes to future webinars based on what we hear from you. The survey will also be sent out through email with the slides and a link to the recording after the webinar. Thanks again to our presenters, our partners at CMS, and to all for joining us today.